Thanks very much. I used to work in an academic medical center, and of course I always was in the habit of showing slides, so I hope you'll forgive me for my habit of doing this. Someone said that it gave me a definition of a specialist. It's a person from out of town who's got slides. So I wanted to do this mainly so I wouldn't miss some points that I wanted to make in case they don't come up in the Q&A. So I'll just give this brief presentation, and we can expand on any of those points that we bring up. If I could have the next slide, please.
You can just advance, perhaps, the green button.
Oh, yeah. Okay. Thanks. Okay, the current concepts of Parkinson's disease, most of which you know, that it's a progressive multi-system disease with motor and non-motor fluctuations, dysfunction that we have discussed. The problem is more than dopamine deficiency, and this has been brought out by our speakers. And it requires a comprehensive evaluation, diagnosis, and management. The diagnosis of Parkinson's disease is a heavy thing for both the physician and the patient. And I think it has to be taken very seriously, has to be done carefully, as does the management and ongoing follow-ups. So you're familiar with the stages of Parkinson's disease. This is the original Hohenjahr stages in which there are mild features, usually starting on one side. The person's able to do the activities of daily living without any trouble. And then as it progresses, the signs and symptoms become bilateral, or both sides. There's more slowing up, and tasks are getting more difficult. Loss of balance and falls can occur after that. It never occurs very early on in Parkinson's disease. If it does, you have to be suspicious of another disorder. And then the person needs some help with activities of daily living and can't live alone. And then finally, they're more disabled, requiring nursing care or and in more advanced stages. So the diagnostic criteria are still based mostly, at least clinically, on the motor features to start with. It'd be hard to diagnose it without those. Bradykinesia, or slowness of movement, is a key one, and that's usually tested by having the person move their hands, watching them walk, etc. A tremor, which is usually a slow alternating tremor that's present at rest. It can also be with posture, in which there's rigidity or increased tone, resistance to movement through the range of motion, and usually an asymmetric onset. Postural instability, as I mentioned, is a late feature. We test it by the traction test to pull gently on the person's shoulders and see if they fall back into your arms, or the history of falls. And levodopa responsiveness should occur if it is Parkinson's disease. If those two things occur, if the postural instability occurs early, and if levodopa responsiveness doesn't occur, we may be dealing with something else. A lot of diseases can mimic Parkinson's disease, and we can be fooled either as physicians or specialists or family doctors to think that it is something else. So there are advantages to the patient, at least seeing a neurologist, a community neurologist like myself, in addition to the primary care physician. We reserve, I reserve the referral to Dr. Jog, or he'd be overwhelmed, with more complex cases that require his expertise. So by seeing a neurologist, you can be somewhat more certain about the diagnosis, and it can be made earlier on, perhaps, not allowing the disease to progress before treatment is instituted. It's been shown in this article by Willis in Neurology, the journal Neurology, in 2011, that all of these things were better when the patient saw a neurologist than they saw a primary care physician or family doctor. There were reduced hip fractures from falls. Falls were less common. Reduced placement in skilled nursing facilities or reduced putting patients in chronic care. Reduced mortality rate. And more aggressive therapy can reduce the complications of immobility, such as deep vein thrombosis, chest infections, and deconditioning. This graph shows the improvement with neurology versus the less problem with survival if the person is seeing the neurologist. Now, this is a standard. This is an averaged graph. It doesn't show the standard deviations or the variability among patients, and many patients can, of course, have a fairly good normal lifespan, but the disease is progressive in general, and you can do better if you see a neurologist. I don't mean that as a plug, but just as a fact. So again, this is the 6-year survival, and this from the same article, showing that the survival rate was certainly higher for 6 years if the person sees a neurologist than a primary care physician. Usually the case anyway. This shows some racial and sex disparity there. Now, I think it's fundamental that we make the correct diagnosis, and some of these other diseases can resemble Parkinson's disease, and we've seen patients with communicating hydrocephalus. This is a CAT scan showing that, with the ventricles looking somewhat rounded, this angle between the ventricles at the front being very narrow, indicating it's probably communicating hydrocephalus. It can cause slowness of gait, unsteady balance, and so on. They don't get a tremor with this, but they can look like Parkinson's without the tremor component, and it can be misdiagnosed. And these patients can benefit from shunting the hydrocephalus. Bifrontal lesions in the frontal lobes, can cause some slowness of behavioral slowing and also some gait problems and so on. And then there are the Parkinson plus syndromes, which are different from Parkinson's disease, although they resemble it. They tend not to respond as well to levodopa, and or may not respond at all. And these are more widespread disorders in the brain that are either due to accumulations of tau or synuclein, similar to Parkinson's patients, but the distribution of the disease is more widespread. Multiple strokes, so-called arteriosclerotic Parkinson's, kind of a bad term, but these patients can also slow up, have trouble swallowing, have slowness of gait and all that sort of thing too. And certain drug side effects, neuroleptic drugs, valproic acid, which is commonly used in epilepsy and in psychiatry, can cause a condition that's very much like Parkinson's disease, just looks like it. And one needs to be careful, go over their the drug regime that they're on, and see if that might, if they might have another cause for their condition. Maxaran is another one that can sometimes give a Parkinsonian-like picture. So the role of, we have limitations, but we have a role of that is, I think, better than one can get with standard family practice, if you don't mind my saying. We, of course, can manage levodopa, carbidopa. We use these COMT inhibitors like entacapone, MAO inhibitors like selegiline that Dr. Jog mentioned. And dopamine agonists and anticholinergics can be used for various aspects of the disease. And we can link with therapists. I think it's very important to realize that Parkinson management is a multidisciplinary thing. There's the family doctor, there's neurologists, there are the movement disorder experts like Dr. Jog, but we rely very heavily on therapists, especially physiotherapists, to assess patients, assess their fall risk, and helping them with their gait and posture. They can, the exercises that are done, and some of you probably have participated in some of these group exercises of like the boxing and Tai Chi and various things that can help balance, keeping the person active. They can provide really good guidelines for that. We have some handouts, but they're not as good as actually seeing a physiotherapist. It's worth seeing one, even if you just see them once or twice. I know they're not covered by OHIP, but your insurance may pay for it, or even if you have to pay out of pocket, it's usually worth seeing them at least once or twice for assessment, at least once as the disease is progressing. The management of non-motor complications, I think most neurologists are quite aware of those. The orthostatic hypotension, treating the drops in blood pressure that can be part of the disease and also aggravated by the treatment with L-DOPA. Dyskinesias, which are involuntary motor movements, which are side effects of the drug, really, that can be helped by redistributing the doses of the drug, the size of the dose through the day, and also using amantadine to help control these dyskinesias, which can be quite miserable. Hallucinations and psychosis can be managed with changing in the drug regime, or sometimes by using drugs to block antipsychotic drugs, such as clozapine or quetiapine and so on, which has fewer Parkinsonian side effects. Autonomic dysfunction, and that's been alluded to, the problems with the gut, with nausea, and also pain management, which can be from various causes, just muscle pain, pains from the joints, or musculoskeletal pain, postural. This is where physiotherapists can also come in handy. That we have to look at all of these aspects in managing patients. And then the more advanced stages, I shouldn't use that term probably with Dr. Jog here, but the more complex cases, I think that in which we would, I think that if they're complex and there's a lot of wearing off and so on, and we're not controlling them very well, Dr. Jog and company can really help us out. So when to refer? The need for other interventions, and Dr. Jog has mentioned these with electrical stimulation, duodopa pump, which you have a lot of wearing off phenomena, but they're still responding. Freezing of gait, uncontrolled tremor, in which they can hit the thalamus as a site to adequately control tremor, similar to what's done with the central tremor, and severe dyskinesias can help us out. If there's an uncertainty of diagnosis, if you're puzzling, and some of the Parkinson plus syndromes that I mentioned can be a little bit difficult to diagnose with certainty, at least in the early stages, and a movement disorder expert can help us out there. Hopefully we can get by some of these mimics, such as hydrocephalus and so on, without needing their help. And again, these more complex aspects of Parkinson's disease, the needs for advice and expert help, not so much when the disease has run its course and they don't respond to anything, but as the disease progresses and becomes more complex, there we can need some help. Prognostic help, perhaps, as well, especially if there's a diagnostic difficulty. And I think this is probably also important that as research is being done in larger centers, that patients may volunteer to be part of some research projects, new medications that are coming out, and new treatments especially. And if they ever get to the point of being able to prevent the reduplication of alpha-synuclein, which is what causes the disease, the misfolding of this, if there's some, that will be, I think, the real big breakthrough in this treatment. And hopefully, in larger centers like London and Toronto, that this will be initiated. I think that's the end. Oh, take-home messages. Yes, sorry. I don't want to steal anyone's thunder, but I just didn't want to miss this. That Parkinson's disease is best managed in a multidisciplinary manner with the GP, the neurologist, physiotherapist, the OT, who can help improve the safety in the home and lessen fall risk, or as the case gets progressive. Movement disorder specialists and others can be all very helpful in managing the patient. And don't forget that it should be really dealt with in a multidisciplinary manner. And a holistic approach, meaning taking care of the motor system, but also the other aspects as well, the non-motor aspects, the depression, which occurs in about 40% of patients with Parkinson's disease, and other aspects, pain management, etc. These aspects have to be considered as well. I would advise patients to keep a diary of their disorder and think of things that they want to ask the specialist or the super specialist. Bring a spouse or a friend to the appointments. I often think it's helpful when you turn to the spouse or someone and ask them, when do you think your loved one changed? And they usually say, well, and when they say well, I always think that needs to be followed up. They've noticed something had changed, maybe before the patient had, and that's usually valuable. That can be helpful in knowing when the disease is really onsetting. And you may find some symptoms that really don't maybe even fit with Parkinson's disease. It's very important to keep active, as Dr. Jog said. Keep active, keep involved, and I think group support is very good because it's good for the spirit. Also encourages increased activity, keeping up with the others, etc. Be forthright and tell the doctor what's bothering you. Don't hold anything back, and also be good to yourself and try to enjoy life and get out and do the things you'd like to do as much as possible. That's all I had to say, but we'll expand on some of these things and probably some things I haven't thought of. Thanks very much. Thanks. Oh, thanks. Okay.
Thank you, Dr. Young.
Okay.
Lauren, would you like to come up, do a brief presentation, and kind of explain your role?
Thank you. So my name is Lauren Gardner. I had that nice introduction already. I think I do have some slides here as well. I was originally invited to take part in a panel, and then I was at the 11th hour invited to bring along some slides if I would like. So I admit I hastily threw together some slides. Please recognize there may be some typos. I do also, this is my first time speaking to a group where I haven't been able to hide them virtually while I'm speaking to a group. So I have some notes here as well as my slides on my phone. So I'm just going to pull them up for a little moral support, if anything. So I'm hoping we'll go through some slides really quickly and then hoping that these can promote a little dialogue around being your own best health advocate, and we can move on to some questions. So do I have this one? Great. So the perspective that I'm bringing here today, I'm a nurse practitioner. I work with the Southwest Frail Senior Strategy, which has backbone support through St. Joseph's Healthcare in London. I'm from Port Elgin originally and have returned to the area My role is regional. I do support work all the way from the tip of the peninsula and into Elgin, but of course, working with our partners around Waterloo Wellington Group, the Simcoe area, Erie St. Clair. So we're all kind of working together to try and say, how can we improve health outcomes and experiences for older adults using our healthcare system? And how can we start to really integrate things locally? So a lot of the questions, I heard some questions in some of the earlier talks to say, how can I access some of these services? How can I know what the left hand is doing and the right hand is doing? Are the different teams talking to one another? So that's what we're really trying to kind of move the needle on ever so slightly in our system. So there are folks living with Parkinson's disease, and living with any chronic illness really is challenging enough. It's challenging enough without additional challenges of navigating the healthcare system. Perhaps at the time of diagnosis, you're entering into this maze. You feel like you've got to, somewhere along the way, you're starting to get pointed in the right direction. You're saying, okay, I've got my multidisciplinary team. I know a few folks I can rely on. And then, as is the nature of many, many chronic illnesses, Parkinson's disease included, we hit a snake instead of a ladder sometimes, and something changes for us. And all of a sudden, the approach we had to navigating the system just changes. It's pulled right out from under our feet. So it is quite challenging, and that is unfortunately one of my take-home points today is this is confusing, and it's okay that it feels confusing. So would anyone like to take a stab at following that pathway for me? No?
I think you have the right red arrow wrong.
Yeah, you got it. You figured it out, yeah.
The others are perfect.
So I show you this map. It's meant to be startling. This is indeed a map that our team put together of just the specialized geriatric services and how they interact with one another only in the Southwest. So this is a tiny little corner of the healthcare system, and that is what it looks like when mapped by folks who work from within the system. So it is confusing. It feels confusing because it is confusing. So I just kind of wanted to say we're in this together and commiserate with you. When the system feels confusing, that is because we inside the system are also navigating changes to what we have access to all the time. But we are, in fact, headed in the same direction and hoping that we can try and navigate in a meaningful way. So I did just put together these few tips, again, kind of anecdotally, what I've recognized have been useful for working with some of my patients in the past. And as you can see, actually, some of them are echoing what Dr. Young had to bring to the table here, and we can certainly speak through them a little bit. Initially, kind of, as Dr. Young said, sometimes 2 sets of ears can be better than one at an appointment. So these are tips for getting the most out of any care interaction. When you're seeing some of your providers, this can be a way that you can, just a bit of practical advice. A lot of it is very things you have perhaps thought of, but can sometimes be nice to have that reminder. So when a lot of information is coming at you, it can be helpful to have a second set of ears to catch all of that information. I would encourage you to write things down, or if writing is not a good option for you, using an audio device recorder or something like that. I would encourage you to write things down during the appointment as well as between appointments. If you think of a question and you're like, oh, I'm not going to forget to ask that, I would encourage you to write it down and bring that along with you to your next appointment. And as you're learning things within the appointment, you can go ahead and take some notes if that is helpful, or record something, take a little voice recorder along with you, or ask your care team to write something down for you or provide you with a hard copy if that's helpful. You can always do that, and sometimes, again, lots of information can be coming at these appointments. It can be really helpful to have kind of something to review afterward. And on that note, I'm happy to provide this as a bit of a handout, so you don't need to take notes of this part. The next thing I have is learn who to contact for what and when. So knowing, between appointments or as things change for you, you're going to recognize certainly questions will arise, a little bit of lack of clarity about where to turn might arise. And so knowing within your care team, which could be, maybe your primary care provider is your touch point, maybe it's someone else within your primary care team or within that multidisciplinary team, getting a clear sense of when can I call you and what should I call you for can be a really nice way to not have to try and make those decisions in a crisis situation or in a situation where things are already feeling overwhelming. Find out what to expect next. So when you're in those appointments and having those care interactions with folks, it's okay to say, when should I expect to hear from your team again? Are we gonna plan for a follow-up? Should I expect to hear from a different team member? If I don't hear from a different team member, who can I call? It's very much that squeaky wheel gets the grease kind of thing. And then the final point that I have to make here is, please feel free to ask these questions. We as your care team really do want to help and support you to understand this. As I mentioned, the system is confusing. It's confusing for you. It's confusing for us. We hope we can start to move the needle on that. But in the meantime, our role really is to support you to understand where things are at so you can be in the best position to make decisions for your own healthcare. You know, the way I like to say it to my patients is, you're in the driver's seat. I can certainly be a map for you. I can offer you different routes along your journey. I can direct you in that way. But you are ultimately in the driver's seat and making those decisions for yourself, so you can absolutely ask all of your questions to be sure you have that understanding. This is my very last little slide. It is really quite important to have an ally or two along your care journey. And so I have a quote here from Dutch gerontologist Jan Baars: "Autonomy requires collaboration." So certainly for folks living with chronic illness and living with Parkinson's disease, as much independence and autonomy you can have in your own care decisions and moving through your care journey, collaborators can be really helpful in that. Collaborators in your life, as well as collaborators on your care team. So finding someone within that multidisciplinary team that you can trust can be a really helpful way that you can trust and that you can reach, is the other key little point I put there. So someone you can reliably reach out to can be a really nice way to start to know where to turn when things do feel confusing. That's all I've got there. Okay, so back to you. Thank you.
You don't think we're going to let you guys off the hook that easy, do you? I get the first question, so everybody's been waiting. Big question for a lot of people facing a diagnosis, especially without a family care physician, is how do they get a referral to any of your 3 levels of care? And I'll open it up. Who wants to take the first stab?
I can jump in on that one. So this is unfortunately a really challenging situation in our current health human resource crisis. And I know particularly in Grey Bruce, we do not have a lot of avenues toward care for folks without a primary care provider. So for some folks that have kind of, wherever you've received your diagnosis, is that kind of what we're talking about? Someone who has received a diagnosis?
Well, or have the symptoms and could be in an emergency room or an emergency department.
Sure. Okay. So there are emerging pathways for folks that are not connected to primary care around, certainly within the Southwest, but they are kind of in, their back shelf, bottom drawer, kind of not accessible really. And so it can be a really challenging thing. So one of the key things I can suggest is wherever you are seeking that first care, really make it clear to the person in your care team, I do not have a primary care provider and I need a next step. I need a phone number, I need someone I can contact, I need someone that I know I can rely on. They may, often a default there is to connect you with a care coordinator in what would be kind of the legacy LHINs. And so often that person is a really useful source in beginning to navigate the system. I know in my role, I connect often with care coordinators within the legacy LHIN organizations whose name is escaping me right now. But that can be one route that they can start to help you in that navigation piece, which can be such a critical moment, especially at a time of a new diagnosis when everything is a little bit unclear anyway. Beyond that, we actually have a new virtual walk-in, virtual urgent care option through GBHS Owen Sound, so that's a local resource. Again, I'm speaking mostly to local resources here, but any kind of walk-in clinic, urgent care clinic, that sort of space can be a good first step to start to make that next connection. So again, that's my point around don't leave without a next step. Really, if they're saying, okay, here's your diagnosis, off you go. People are busy. They may not realize that you don't have someone to follow up with. So being really, really clear and advocating for yourself to say, I need a next step. And if you're telling me someone's going to call me, let me know who I can call if I don't hear from them and by when.
Thank you.
I'd like
Okay.
to,
Please, go ahead.
sorry, I'd like to just to support what you've said, and we should be aware that specialists need a referral from another physician, so there has to be that link with a physician, either a Emerge doc or a walk-in clinic or someone. But as you said, be sure you're clear about that you don't have a family doctor, and then they can refer you to the neurologist and or a movement disorder clinic. Once the patient is seen by the specialist, though, there is this problem, what do you do next? Or how about the follow-up? And as a community neurologist, I am obliged to follow these patients with Parkinson's and see them at periodic intervals. And I end up often functioning as a family doctor for them, quite often in dealing with some of their other complaints. And I'm terribly out of date with some of these things. You know, managing if they have arthritis or some other, a cardiopulmonary condition or something, in which case I would get one of my colleagues to see them. But I do take that seriously, as I think any community neurologist would, especially in patients who don't have a family doctor, that you have to keep that follow-up and keep the lines open too if they need to call you.
Dr. Jog.
Yeah, I have an additional really important thing to talk about in terms of the non-motor symptoms that you heard. You saw the list, right? Parkinson's disease, tremor, rigidity, bradykinesia, and postural instability that Dr. Young so elegantly presented are 4. Those others are 28. Right? And so I'm not a gastroenterologist, I'm not a urologist, I'm not a sleep medicine doctor, I'm not a respirologist, I'm not any of those things. Psychiatrist, but access to any of those subspecialties from us is very poor. So in fact, we manage constipation, we manage autonomic dysfunction, we manage sleep disorders in these patients, hallucinations, and all of those things that are actually nothing to do with my training whatsoever. And this has become a really, really important point in the discussion at our subspecialty level as to what is our scope of care. I mean, for example, and it might sound crude, but I don't know how to do a rectal exam. I mean, I don't. I did it in medical school, and that was previous century, literally, right? And so, and so now, even if I were to actually try it, I don't know what the hell I'm going to feel, right? I don't know. And so, yet somebody's constipation could be a colon cancer, right? And now I'm saying, well, actually, why don't you just take some Restrolax, increase your Senecot, take this and eat and that and some chew on paper, whatever. And then they've got a colon cancer, which I don't know how to diagnose. So and if, in Leonardo da Vinci's time where it didn't matter, it matters now because I don't know how to scope somebody. And so same thing with urology. If you're having trouble with male dysfunction, nocturia, whatever, it could be prostate problems. Again, I don't know what I'm going to feel because I don't know how to do those exams. So it's become really, really important to be able, psychiatry at least we can manage because it's kind of overlapping with neurology, but many, many of these things. And the second part of this is if I refer to a urologist, then that referral information comes back to me, not to the other people. So what ends up happening is that I then end up having to take over. I just don't have the time to be able to manage somebody's 16 different non-motor symptoms, just out of the scope of practice. So it's dangerous medicine is actually what I wanted to make a comment of. It's not simply that you don't have, it's actually just dangerous, in terms of management.
All right, the floor's open. Oh.
Good question back to you. Would you then prefer, like you say, you see this, you make the referral. Would you then prefer that your patient then says anything sort of outside your scope, I want you to send to my GP?
Well, I mean, the problem came about because of what both of them actually said in terms of family physicians. We have this all the time in terms of we don't have anybody, so we do manage all of these people. We don't make the referral. To get a psychiatrist in London, even though there are 100 of them, not sure exactly what all of them do, but no, that came out wrong. Sorry, I mean in terms of what they're not going to look after our Huntington's and just don't. They refuse the referral. And so then I've got somebody hallucinating in front of me. I got to manage their hallucinations. I have to. I don't have a choice. And so then we do. And so we've now become those things. But we are concerned about the standard of care we're offering these patients. And it has happened. We've had patients with esophageal cancer that had a swallowing assessment done for Parkinson's, and we found this cancer. Right? And God knows how many we miss because we don't know. Right?
I'd like to make one more quick comment about the unattached without having access to primary care providers. So certainly, this is a systems issue, and it's affecting all over the place. And so certainly, as we're moving to more toward the Ontario Health Team's approach, I'm not sure if people are as familiar with that as it's happening, but pending our upcoming provincial election. But in the meantime and ongoing, this is the sort of thing that is unfortunately above the heads of many of us as providers. This is a kind of a government level thing. And so lobbying your MP, speaking about this is an important thing for we as patients, we as users of the healthcare system, we as people that love users of the healthcare system, it is a really big issue. I really appreciate that you went and said that this is a really challenging situation to find yourself in a specialist clinic trying to manage some of these things that really are meant to be well managed at the level of primary care. And so
regularly we will get an orthopedic surgeon refusing to do a knee or hip replacement because the patient has Parkinson's disease. And they say, okay, Parkinson's disease, hip replacement, and it's ridiculous, right?
They don't understand.
Yeah.
Yeah.
We have a question over to the left here.
On a lighter note, who can I see in the health team to teach me how to use my laser Q cane?
That laser Q cane, I haven't yet figured out how to use. Because I'll tell you why. The reason for that is so difficult is because you have to. It's a switch cane, right? The usual. Yeah, you have to push the cane down so the laser light comes on, then step on it, then lift it, and then put it down again, then step on it, lift it. Boy, by the time I've done my fourth step, I'm completely out of sync. My foot is up and the laser cane is down and I'm this way. And I find that laser cane very difficult to use in general. Laser walker, very easy to use. But yeah, because the laser light is constantly on, that you're pushing and rolling. The cane, boy, you don't need to do a mocha anymore.
Answer, Lauren. Go
I
ahead.
just wonder if maybe an occupational therapist, maybe not Dr. Jog, I guess.
Clearly not. No, sorry.
Maybe.
Wait a minute, that didn't hit, okay.
If you do have an occupational therapist as part of your team, they are often really, certain team members can be really up on whatever kind of devices that you've personally found to be useful for you. And if you're finding that, maybe that's not the best choice in any situation, if you're trying one device, finding it's not working for you, they can make a really meaningful suggestion of a different kind of device. So occupational therapist would be my go-to.
Better answer.
If I can just follow that up, Lauren, that brings up a good point. How do you open up a file, for lack of a better word, to get an occupational therapist?
Yeah, certainly. So again, if you have care team members, if you have a primary care provider, certainly they can make that recommendation. If you have or they can make that referral. Again, locally to Grey Bruce right now, I know through the Legacy Southwestland, that is a long time waiting. And so there are occupational therapists through service provider organizations within the community. Some of them you can access through private pay, which is not a great solution for a lot of us. But you can certainly make that referral from within, if you have a care coordinator, they can make that referral quite speedy. They can do that kind of in amongst one another. But otherwise, your primary care provider or your multidisciplinary care team associated with if you are connected to a movement disorder clinic or something like that, may have that as a member of their team.
No, we don't.
You don't?
Problem.
Oh.
We cannot, because the acute care hospitals are not able to fund at all any multidisciplinary team, like at all, zero, not possible. Because the physios are on the ward dealing with people that have had strokes and chest infections in the ICU. We cannot. The second important problem with it is that even if they see a physio in my clinic, they're from Owen Sound. And it's pointless to have a physio spend 20 minutes with them because they're not going to be connected to this person. Speech therapy is the same.
One thing you can do, since we have an extremely good stroke outreach program that is funded and seems to work quite well, if the person has had a stroke or a TIA even, you can get home care, you can get outreach teams to visit that person at least for a period of time, and that
good. So
and
I just have to
access the house.
Say query TIA plus Parkinson's disease.
Yeah, if they
Oh,
have that
good.
combination, you can get home care for sure.
Some of the family
OT.
Some of the family health teams do have them embedded as well. So it kind of depends on who's in that care team to begin with. And I guess that's a misunderstanding that I had around who's available in some of the specialty service teams. Again, my area is not specifically Parkinson's disease, so I missed that. But certainly some of the family health teams around, they're now recognizing that there is inequitable access to some of these allied health services. And so they're starting to kind of farm out their allied health providers to other teams that maybe don't have access to some of the same multidisciplinary specialists or multidisciplinary teams around.
But the other thing, Laura, is the change in that team, right? So we were talking about this on the way here this morning, that in Thunder Bay, where I used to run a clinic for 17 years, there was a pharmacist at a Shoppers, very dedicated, spent time with me, 3 days, taught everything, excellent. 6 months later, he's gone.
Yeah.
And now there's nobody there.
Yeah.
And that was many years ago, but it happens all the time. People with allied care are the most mobile, go everywhere. And so then you just don't know who to refer to, and we've no database that says in Grey Bruce, in this location, this physiotherapist or whatever. I have no idea.
Yeah.
So, no. Right?
If I may, I'd just like to mention a couple of programs that we have at PSSO. We have relationships with Western University, and so right now we do have 2 OT students, so occupational therapy students working with us. So if you would like some support with that, you would just need to reach out to info@psso.ca and I can get you connected. In addition, we also right now have a Master's of Social Work student finishing up his placement with us until the end of June. So if you're seeking out any kind of mental health support, we'd be able to help you with that as well. We also have a program called Louder Clearer, which is run by a speech language pathologist at no charge to you, which can help you with your speech if your voice is becoming quiet.
Yes. Do we have any other questions in the group here? Oh, up front here?
So my question is.
Oh, just a second, Mike's coming.
My
There we go.
question is, I completely agree with coordinated service planning. And for those people who are lucky enough to have a neurologist, a GP, all those pieces, how do we actually get them all together? Because I know that each practice is really busy. So how do we get them together to actually create a coordinated service plan?
We don't. Because we're just overwhelmed, I'm telling you. Just submerged in, our waiting list is 18 months at the movement. I have 6 fellows and me, and we're still 18 months away from seeing patients. And it is, we were just chatting about this, that west of Toronto, academic movements are just me, 1%. That all of the region, entirely. Right? And so so, you know, if I decide to go to Tibet tomorrow, it's not a good thing.
What's your waiting list, Dr. Young?
It's variable. We prioritize patients so that if there's something urgent, we can see them fairly promptly within a week or 2. But in general, it's getting to be 6 months or more. But in answer to your other question, I think communication is really important. And I'm sure that Dr. Jog outlines, some scenarios that should be followed if the patient is getting worse or, is having some problems, what to look for on the part of the family doctor or referring doctor. And that helps a lot. And I do the same with family doctors to give them some things to check. Be sure to check the blood pressure, whenever they're visiting, lying and standing, just to see if they're developing orthostatic hypotension and so on. It's important to lay that out in your letters and communications, and hopefully they read them.
Yes.
To follow that.
That's the kicker there
Yeah.
too. And for you as the user of the healthcare system, to know when you last saw your specialist and when you go to then see your primary care provider to say, well, I saw Dr. Jog on this date, I saw Dr. Young on this date, and then they can pull up those notes, and if you give them that little boost to say, they sent you a note, they, you know, because of having had that interaction with them, you'll know they made some recommendations for if this, then this, and if this, then this. So even to just prompt them to say, these suggestions were made at our appointment on January 6th. They can pull up a January 6th note pretty quickly and then be able to kind of refer to that, which is ideally the situation every time, but can be one little boost of a way to be able to remind them these other specialists are involved.
Okay, I think Mandy has a question over here.
Good afternoon. I would like to hear your response to my inquiry with regard to waitlist management. I'm familiar with waitlist management in cancer centers and have been for many years, but I became a patient of Parkinson's. I was diagnosed with Parkinson's a year ago and was informed at that time I would be sent to the motion disorder clinic. A number of months later, I did get a letter, which was somewhat startling, the fact that it would be a minimum of a year to wait. I hadn't been informed of that by my GP. And so I spoke with my GP again recently, and I got another letter. It's 2 years now.
Gosh.
Oh, sorry. I'm going to kind of warp that question a little bit and find out what is the referral process? Because we've heard different things, whether the GP refers to the motion specialist, the neurologist refers to the motion specialist, the GP refers to the neurologist. Like, how does the chain work the best?
Well, I think it's best to probably start with the neurologist. At least that the neurologist can at least confirm the diagnosis or make the diagnosis or have a differential, explore the possibility of communicating hydrocephalus, etc., get a CAT scan done. I think we do one on pretty well everyone who's referred. And can start the patient on therapy and monitor the effectiveness of the therapy to see if they're following that. If they don't, then, you know, your red flag would go up. So, yeah, I think the initial referral from the GP to the community neurologist, and then we would, in turn, ask Dr. Jog to...
And not to put you on the spot, Dr. Jog, but is there a different weight to where the referral comes from, whether it's a family physician or a neurologist to your clinic?
For sure, because I mean, you have to remember that, you know, somebody like Dr. Brian Young, who is my professor, right? And so it's not fair to call him a community neurologist, because that is not community neurology. We're talking about people that are usually, you know, recent graduates who are doing lots of headache and epilepsy and that kind of, not this level of expertise and experience. He wouldn't even really need to refer until the patient really defies that aided therapy. But that's not, even regularly from neurologists, what Galit was saying about protein interactions. This happened last week. 2 of the community neurologists in London, one actually referred 2 patients for advanced therapy. But this person really needed to take an extra half a pill 3 times a day. This didn't require to come to us to manage. And it is the level of discomfort about managing Parkinson's disease is extremely high. Right? I would be very comfortable with Dr. Young never referring anybody to me until the time, because I know that there is, you know, no issue. And so the variation in expertise, and that's why, remember I said, what is advanced? Well, it depends on the comfort level of the person, right? And so if a family doctor doesn't know it's essential tremor versus Parkinson's disease, they need to make a referral. He would never need to do that. And so, maybe not never, but almost never. And so the knowledge gap is very wide across, and that's the problem. So I don't triage like that. I mean, the family doctor makes a referral, I don't say, well, send it to somebody else. I tend not to do that, because maybe they don't have anybody that they feel comfortable sending to.
Right. Okay, I know we've got a question back here.
Yeah, good afternoon, folks, and thank you very, very much for your help and everything. It's been very encouraging here today. I wanted to add, though, it's up to us, I think, to be our own advocates for a lot of this stuff. And I had no idea when I got into Parkinson's what the heck I was facing. I was given a neurologist by my GP. I'm fortunate to have a GP, and he's been very helpful and very listening to me. He's been awesome. And he sent us down to a neurologist, which we found out in 2 years later wasn't going to do anything other than give me some dopamine. That was it. That was the extent of it. He didn't even know any other neurologist to refer me to. Went back to my GP, and he said, look, you're going to have to do some research on your own. we're all on computer pretty well now. We can all do kind of research. I got onto PSSO. That's how I first came across them. And they sent me a whole spread of people to get hold of and all this kind of stuff. So that was very helpful for me. For me? Motion disorder specialist, yeah, I needed to see one of those. I'm finally going to see one after a year now, almost 2 years. I'm going to see one in the next couple of weeks, which is awesome, right? But we have to be our own advocates for a lot of this stuff, I think, and it's maybe a little confusing for some people. I can believe that a lot of these people leave the organization because they can't handle it, being in it, let alone us on the outside looking in. I really commend you folks for hanging in there with us and doing such a wonderful job. I do. I thank you so much for that. And the Parkinson Society of Southwestern Ontario has been extremely helpful for me. I first went to the Michael Fox Foundation to get a hold of, who do I get a hold of, and they sent me into Southwestern Ontario Parkinson's company, right? And from there, we expanded it from there. So it's just making a few calls. But you have to be your own advocate, really.
Absolutely. All right, sorry, we're running out of time, and I know we've got one or two questions back there, please, and then we'll wrap her up.
So Dr. Young mentioned having ultrasounds done periodically. Is there a reason for it? If you're
Ultrasound? Sorry?
You mentioned having
Oh, sorry,
ultrasounds
CAT scan.
periodically.
Sorry,
CAT
CAT
scan,
scan.
yes.
Yeah.
Yeah, I think it's a good idea to, because of the potential of mimicking conditions. Admittedly, a classical presentation, you're very nearly 95% or greater certainty of making the diagnosis if it's extremely classical with a one-sided alternating tremor and so on, and the other features of bradykinesia and rigidity. But the person who is slowing up in gait and so on, one can be misled unless you do a CAT scan. Slowing up and so on, it can be seen in a number of different conditions. And that's a key thing with the diagnosis of Parkinson's is bradykinesia, or slowness of movement.
So my husband was diagnosed about, I'd say, 18 years ago, and he's never been told he should have a CAT scan.
Well, I think it's just a good standard of practice to do it. Doesn't have to be an MRI. An MRI is even better, but for certain conditions. But a CAT scan is a kind of a minimum, to me anyway, minimum standard. Would you agree, Dr. Johnson?
Yeah, I mean, I think you're right, but my practice is biased, as we've already discussed. But in general, we don't suggest that any imaging is required. The presentation is classical, and the levodopa response is there. When there are, as Dr. Young said very nicely, there are red flags. So, for example, early freezing of gait, or there's cognitive impairment within the first few years. This is not typical Parkinson disease, and we definitely investigate. But if somebody comes in with an asymmetric rest tremor, typical hypomimia, Parkinson disease, but I'm on levodopa, all is well. There isn't a recommendation by the Canadian guidelines to do any imaging. But these red flags do happen, and you have to be astute about that, for sure.
All right, final question goes to Shelley, or comment.
No, so I just heard both of you talk about our family doctors and our primary care physicians and not having the knowledge and the base of Parkinson's disease. So we have a great program. It's our Parkinson's education program. A few years ago, we actually made that, it used to be a train-the-trainer program, but we switched that to be online, so we call it PEP Online. So there is free access to every medical professional to get a hold of this information and to have a better understanding, should they have a patient with PD, as to how better to be able to help them, maybe before they start to send them to a neurologist or before they get to you, Dr. Jog. What can we do better? Like, how do we get that information out? We have sent it out, it's out there, but how do we get our primary care physicians, and maybe it's just the same thing, they're just as overwhelmed as all of you, but if we could get so they had a better understanding, we could start at the ground up.
Education, I guess, is the best way to do it. Every doctor in Canada gets the Canadian Medical Association journal And if they read that at all, they, there are articles in there that, over the years have referred to Parkinson's and its treatment. But
I think it's the nature of family medicine. I mean, you can even say that the typical knowledge-based family medicine is over. It's too much to know, right? Because there are, 2.8 million diabetics and 70,000 Parkinson patients, and then there are hypertension patients, 17 different medications now for rheumatoid arthritis. I actually don't know much more than I know, right? And I sort of cheat because I know a whole lot about this much, but a family doctor has to know a whole lot about all of those things. So it's really not fair to look down upon our colleagues that are in the trenches, so to say. It is our job to be the ones that are the holders of that expert knowledge, and to say that a family doctor, I mean, my fellows do 2-3 years of fellowship after doing neurology to become movement resource specialists. And a family doctor has got 2 years of family medicine training. It's totally unfair. And I know nothing about epilepsy management at all, and I'm, a pretty good neurologist, but how can you expect family doctor know about side effects of lacosamide? I don't know how to spell it.
Yes.
Honestly.
I would just like to echo that too. So I'm a nurse practitioner. I work with a lot of family care nurse practitioners as well as primary care provider physicians. And certainly, from my experience, nobody is wanting to give anything less than the best possible care.
Exactly.
And so when there is a wide breadth of information that is required to know, and things are changing all the time, which is wonderful, certainly I've heard from this group how well you guys are advocating for yourself, and I think really keep doing that. You're doing a great job, and that is unfortunately a really key part of our healthcare system at this moment, and particularly at this moment when everybody is quite burnt out. And so certainly the great organizations making this education available to all of us as providers is only a step in the right direction. I think that's fantastic. But I do also think that one thing you could expect to hear from your primary care provider is, I don't know, I will find out for you, or I will help you find out. That is just the reality of the situation. If there's something that we don't know about, or that we do not yet have the answer for you, it's about helping you find the answer and helping you connect to the folks that can help you find the answer.
Parkinson's disease, we must remember, is extremely prevalent. It's very common. And I would think every family doctor who sees the wide spectrum of patients is bound to encounter patients with Parkinson's disease. So that it should be part of their educational background that they are exposed to I'm sure they're taught about it in medical school, but
no exposure.
Not much.
Brian, I know this is in the neurology residency program, and I'll stop there. The entirety of the neurology residency program, 5-year program, most residents spend, guess how much time with me? 1 month. That's it. 1 month in the movement restore clinic, and that's oh my gosh, 1 month. Internal medicine residents don't even do rotations on neurology.
Wild.
It's not mandatory on neurology.
Yeah.
How many patients do you think you're going to see with headache and dizzy spells and Parkinson's disease, tremor, whatever it is? Lots.
But if you take a family practice residency, you would think that would be part of it. Think of the common neurological disorders they're going to encounter: migraine, epilepsy, and Parkinson's disease are
Alzheimer's.
3 of the most common disorders that they should have some modicum of exposure to it. You would think. If they don't, their program director should see that they do, I think. Maybe we should.
I've never seen a family practice resident rotate through my clinic in the last 23 years, let alone neurology and internal medicine, 0.
But they could at least get a modicum of information about it.
Yes, they should, absolutely.
I'm going to interrupt. Thank you. Thank you to all 3 of you. This is, I know we could go on for hours. This is one of those topics. So.